So I'm Robin Scott, and I coordinate the Equality Coalition, who are one of the organisers of these webinars. So we're holding them jointly with the Human Rights Consortium and with the Transitional Justice Institute. So we launched, I think, the first webinar back in the summer, and they have so far been quite successful. So we've just decided to keep rolling them on into the autumn and the winter. So yeah, there will be more after this one as well. But basically the idea behind the COVID Conversations webinars is just to explore issues related to human rights and equality that have been brought into sharper focus by the pandemic. So we've looked at a number of different issues, but obviously this one today we're looking at caring. So more specifically, we're going to look both at care homes and how things within care homes operated during the pandemic, and also the problems that arose within them. But we're also going to look at unpaid caring and how unpaid carers and the people they're looking after were impacted by the pandemic. So this isn't actually one of my main specialist areas, so I am going to keep things fairly brief and just let the speakers really speak for themselves. We actually have 5 speakers today in total, so we're going to have to try and be quite tight with timings, but hopefully everybody will get a chance to speak for 10 minutes. And then, as I said, we'll have questions at the end. So just before I pass on to the speakers, I just want to introduce all of them just really briefly. So firstly, we have Patricia McKeown, who's the Regional Secretary from Unison, the Public Service Union. She's one of the most senior trade unionists in Ireland, and she is also a long-standing co-convener of the Equality Coalition, which, as I've already said, I coordinate. We also have with us Anne-Marie Gray, who's a Professor of Social Policy at Ulster University and co-director of ARC, which is a joint Ulster University QUB research centre focusing on social and political issues in Northern Ireland. Next, we have Siobhan Casey, who's Director of Marketing and Business Development for AgeNI. She's also a Senior Atlantic Fellow for Equity in Brain Health. Siobhan has worked on a number of recent projects, including developing innovative support for people with dementia and high-profile awareness campaigns to combat loneliness. Finally, we also have Fiona Mcmahon from TIDE. She's a career carer involvement lead for TIDE, and TIDE is a network of present and former carers of people with dementia. TIDE are part of the Dementia Voice campaign for better recognition of carers visiting rights in residential care settings. Now, with Fiona, we have Liz Stitt, who is a TIDE member and is a carer for her husband who has Lewy bodies dementia and is in residential care. Previously, Liz worked in Dunstores as a regional visual manager, but she has been retired for 11 years. So Liz is actually just going to tell us a little bit of her own experiences of caring for someone during the pandemic and the very issues that arose because of that. So yeah, I think that's probably enough for me already. So I'm going to move on now to Patricia, if she's ready to speak, from Unison.
Thank you, Robin, and good morning, everyone. I suppose we've been prioritising this for what seems a very long time now, late February, early March, and we've had 2 big priorities. We're the largest union across the health and social care sector, so we've had a mission to protect our members, the health and social care staff, but also to protect the clients and patients. And if we start with the staff in the care sector, they're predominantly women, predominantly low paid, predominantly outsourced. And in care homes in particular, you find a very large concentration of Black and migrant workers. The employers are some responsible employers, but I have to say the majority of them are hostile and anti-trade union, and that has made tackling the pandemic that wee bit more difficult. The client base, as you all know, mostly older people, also people with disabilities. And in early March, as a union, we wrote to all of the employers. I think we wrote to over 300 employers at that stage, urging them to take some steps to protect, for example, sick pay for their staff. Most of their staff would not have been entitled to any form of sick pay that compensated, you know, it might be statutory sick pay Our worry was that staff would contract COVID and would still be forced to go to work because of the economic pressures on them. That didn't meet with a particularly positive response, although some employers, a minority often, did take some action. By mid-March, we were writing, not to politicians, not to the Minister for Health at this stage or the executive, but we thought the smart place to go was the Chief Medical Officer. And we were asking him to move on two things. The first was care homes. We wanted to see a spotlight put on care homes and domiciliary care. And we were citing the Italian experience, which we were watching with some horror unfold. And the other issue we were pressing on was testing. And none of us would have missed Dr. Michael Ryan of the World Health Organization at that stage and his mantra, test, test, test. And we were extremely concerned that we were blindly following Public Health England and not doing our own thing, not taking the steps that needed to be taken on this island to protect this island and its people from the spread of COVID. It would take a very long time before that policy would turn around. By late April, guidance was issued, and I have to say we then challenged that guidance because it did not do what needed to be done either in domiciliary care or in care homes. And when we eventually got to a policy, a declaration by the Minister and the Department of Health that everybody inside the care homes would be tested, that was, I have to say, down to us. There's still big problems around that. There are big problems about how well the system is working. It appears to be working better than the system in England, but nevertheless, there are still flaws in it. There are issues around who's monitoring that, because we have had concerns from the beginning that the RQIA was repurposed. We thought at a time when it should really be in hyping up and really heightening inspection and making sure that everything was as it should be to protect the residents, it was switched into a role of supporting the private sector employers instead. Now, despite the hostility from many of the private sector employers, we did go to town and made public calls for the government to move in and support them on key issues such as sourcing PPE. And there are still issues around it. Let nobody think that the issues of PPE and guidance are yet resolved. They have improved considerably over the last number of months, but there are big issues still to be attended to. We did secure a sick pay victory in June, and it was paid out at that stage, but not backdated. So we were already looking at a workforce with financial hardship. And again, the implications of that for footfall. One of the things that characterized our care homes was the fact that it was a very transient, temporary workforce. Those who owned chains of nursing homes or care homes were also moving the workforce around those chains. So footfall was high, and there was only one way that COVID could get in. Either the discharges from hospital, which were not being tested, none of the residents or patients coming back in to the residential setting were being tested for many weeks. And also the staff were moving around and not being tested. So when COVID arrived in the care homes, it was brought in. And it was pretty obvious how it was coming in, but the system was pretty slow to react to what needed to be done. There are still issues, believe it or not, around some instructions being given to some of the care workers about when it's appropriate to wear or not wear PPE. And there are still some resistance, even though everybody's supposed to be tested, there's still some resistance to whether you should be tested. And, you know, we're now in we're in the foothills of the second wave. And a very worrying factor for us all has to be the fact that increasingly we're seeing people with COVID who are largely asymptomatic. And that does say to us, you must test everybody in the care sector. You really must keep testing, and you've got to do the tracking and tracing. And I'd be very worried about how this Pillar 2 testing system is going to be able to respond to that. We haven't had an answer yet on sick pay going forward. We've seen 55 million has been announced by the UK government for England, part of the infection control programme, and there will be Barnett consequentials for us, but we will be demanding that that money be ring-fenced to make sure that there is sick pay paid in the care sector, so that we are protecting the workforce and we're not forcing sick workers into either residential or domiciliary care setting. We're hearing that there's going to be a domiciliary care review, but at this stage we don't know who's going to conduct that review, who's going to be involved in it. And I think we all need to ask, well, what kind of lessons have been learned to date? We are still unison alongside Amnesty International and the CAJ are still pressing for an overarching public inquiry into what has happened in our care homes. Big equality and fundamental human rights issues there. What has happened so far has only been termed what is a learning exercise, and while we've contributed to that learning exercise, it is not a substitute, and that inquiry, I think, must take place. Over the next 6 weeks, our main preoccupation is going to be still pursuing whether we can guarantee sick pay for the workers in the system, and where we are on testing and where we currently are on PPE, and those are still the big issues. But we're also, as you know, shaping up for a long winter. We're saying that we can no longer go on accepting this thing called winter pressures, which results in the death of vulnerable people from flu. Not just COVID, but from flu. It's coming. And if we have learned anything, then it must be about the steps that need to be taken for prevention, prevention and control of any virus, be it COVID, flu, or whatever. And I think there's an awful lot more work to be done on that. We have been pushing both the enforcement agencies to step up on this one. We want to hear from the Equality Commission and from the Human Rights Commission their views. Now, you know, the Human Rights Commission is saying it's sensitive to a public inquiry or supporting one, but actually they're the enforcement agencies, and we think they really have got to step in to protect the rights of the clients and the residents and the patients and the rights of the workforce. That essentially is where we are at the minute. Current concern that we are working on in response to what we're hearing from our members, many of whom are carers themselves, day centres, which are so vital in providing some respite for carers as well. They are not back to where they were in the pre-COVID level, and I think we've got to be very concerned about that. This is a potted version. I don't want to run over my 10 minutes, but I have to tell you that since late February, we have lived and breathed this every day of the week. Some of our members I see are online here, and they have been absolute champions in terms of what they've been trying to do. And this is a particular part of the workforce that has taken enormous risks in order to safeguard our vulnerable. And we need to see government, Department of Health, and the public health and medical experts step up to the mark to back them and make sure that both they and the clients are protected. So I'm going to stop there. Happy to be dealing with more detailed questions later. Thank you.
Thanks, Patricia. That was really great. Very detailed, but you kept it to time exactly. I think that was exactly 10 minutes. So thank you very much. So yeah, I'm now going to pass things over to Anne-Marie, provided she's ready, from Ulster University.
Yeah, thanks very much, Robin, and thanks, Patricia, who's really highlighted, you know, some of these critical issues to do with the workforce. What I'm going to try and do in 10 minutes is just to link some of these issues to social care policy more generally. And I think we could summarise maybe the COVID-19 impacts on social care by saying it's impacted on the quality of care and that terrible scale of deaths in care homes that would have been unthinkable before this. The questions that Patricia has raised about the lack of PPE, the issues around sick pay and so on, clients discharged to inappropriate facilities in a rush, not having access to reablement and the impact of that on their quality of life, and then the restrictions of people living in care homes and the abandonment of those routine inspections. And I think overall that those quality issues raise really critical questions about the resilience and the preparedness of the social care sector to deal with this pandemic. Secondly, there's the impact on unmet need, which was really unquantifiable before the pandemic. We know just from a BBC analysis that about 4,000 domiciliary care packages at least were suspended in Northern Ireland, and the impact that has had on unpaid carers, which I know Liz is going to talk about later as well. Patricia has raised the impact on the workforce conditions and the pay, and the laggardness with which they address the sick pay is just one example of that. One thing that it has also exposed is the disjointed nature of care in Northern Ireland, that systemic divide between the healthcare system and the social care sector, which even in a notionally structurally integrated system has made an integrated response impossible. And I think there's real lessons there as we move forward with the transformation of social care, of health and social care in Northern Ireland. So I think a clear picture undoubtedly has emerged of a social care system under significant pressure, a workforce struggling to cope. But actually what I really want to stress is that none of these problems are new. The pandemic has simply brought to public attention problems which come from years of underfunding and political neglect of social care. And actually gender is an important factor in that, you know, this long association with care work, with women's work, and the lack of value attached to that. And I think the roots of this problem go right back to the 1940s, when that fault line between the NHS and social care, the NHS free at the point of delivery, and social care, which was means tested, was established, and that remains really the fundamental source of inequity and fairness in this system. We might ask, you know, 70 odd years down the line, why the NHS has always held such public affection, for instance, and the social care system hasn't. Not just in Northern Ireland, but across the UK, more people work in social care than in the NHS. So here it supports over 40,000 jobs directly. As Patricia has said, there are really major problems always, not just during this pandemic, of recruiting and retaining staff. There's serious inequities between the conditions of staff across the various sectors, the voluntary sector, the private sector, and the statutory sector. And that's been noted by the Department of Health's own report on the workforce. And the outsourcing of care, which has taken place in social care since the 1980s, has ultimately resulted in a race to the bottom, impacting on the human rights of workers, but also the human rights of users. And the lack of investment actually in workers has been identified in much research across the UK as a major factor creating risks to the human rights of users. One thing, just maybe to pick up on something that Patricia has said about the demographic of care workers, one thing we really lack in Northern Ireland, which impacts on our ability to analyse all of this, is a good, robust data set. So in England, for example, the Personal Social Services Unit at the University of Kent is funded by government to collect and analyse that data, and they have incredible data on the movement of workers, you know, the demographic of workers, the transient nature of this workforce, the qualifications they have, and so on. And we don't have that data, and we need it. I'm not going to say too much about unpaid care because I know that Liz is going to pick up on that. But in policy terms, we also lag behind here in terms of strategy for care. Strategy is now very, very out of date. It's over 13 years old. We know there's questions around carers' assessments, how they're done, when they're done, and what results from them being done. One of the critical things I think that has been highlighted during the pandemic, but something that should have been more of an issue in the past, has been the appropriateness and the ability of that private market to deliver the bulk of social care provision, whether it's domiciliary care or whether it's in residential care. And that fragility in that home care market has created substantial risks for users. And I know the Minister alluded to this at one point when he was linking the demands for resources for PPE to the profits being made by the large providers in the care home sector. But ultimately, the system we have for home care provision is not sustainable. And I think now there is a very strong consensus across the UK, which we have to build on, for a fully universal social care system, fully integrated into the NHS and into health services. These are really difficult policy decisions to be made, and there's decisions to be made in the short term and there's decisions to be made in the long term. I think in the short term, there needs to be significant resourcing to deal with the immediate trauma and grief for the relatives and people living in care homes, and for the emotional toll that it's taken on workers as well. I would definitely support the call for a public inquiry around what happens in care homes. There's undoubtedly a need for that. But we do have to think in the long term as well about how we can address some of those issues. And we've been embarking is maybe not the right word, but we've gone some way down the road of a transformation of care, which has really absolutely ignored the social care sector to a very large extent. And I think if we've learned anything from this pandemic, we've learned that we have to now stop, take stock of where social care needs to be in that transformation program. Professor Bengoa, all of the 5 major reports that there has been have said very, very little about social care. But Bengoa did mention that there needed to be more drilling down into the social care sector and more into integration of care, but very, very little has happened on that. And that's what I would be saying for the one big thing to come out of this pandemic is that we need the public inquiry certainly into the care homes, but we need an inquiry, a full inquiry into what we want from the social care sector in the future, what we want as a society, and how that's to be funded. And I think the scale of that is so big that this has to be something that's done across the UK jurisdictions, because what we need to be done, what needs to happen to social care, in my view, cannot happen within any of the models of social care that we have at the moment. And just finally to say that politicians, I think, now recognise that something has to be done to social care. I think they should have the courage and the conviction to do that, based on the knowledge that this is what the bulk of citizens in Northern Ireland and in other jurisdictions want. And we know that from all of the public attitude surveys. We know it from the Citizens' Assembly on adult social care that was held here, and on the Citizens' Assembly which the Health Committee in Westminster funded in England as well. So thanks very much for the opportunity.
Thanks, Anne-Marie. Another really great presentation. Just a reminder, if you have any questions that you want to put to any of the speakers, just to put those in the chat box and we'll come to them at the end. But before that, now we're going to move on to Siobhan Casey from Age NI.
Good morning, everybody. I'm just going to see if this slide presentation working. Is it showing there? Yeah? Okay. So I'm going to talk now about sort of I'm going to see if this is from the beginning. A report that AGNI just launched the other day on the lived experience of people, older people and carers during the pandemic. I think, as we know, that around the world, older people and carers are bearing the brunt of it. And people over 65 are making up 90% of all deaths attributed to COVID. So the pandemic, as some of the speakers have said earlier, has exposed both health inequalities in Northern Ireland, with age being a significant factor, as well as living in areas of deprivation. So it has had a significant impact on older people and carers who were previously independent, living life to the full, and it's affected their physical and emotional well-being in terms of anxiety, loneliness, deconditioning, and also ageist assumptions. So this report, what matters is sort of showcases what really matters to older people, and it features the voices and experiences of our consultative forum, of our service users, of age sector groups right across Northern Ireland over the last 6 months. What we wanted to do was to recognise the wide-reaching and intensely felt practical, physical and emotional effects of the pandemic on thousands of older people here. Many of them, as I said before, were living life to the full. But by bringing their voice into the public arena, we hope to be able to shape how preparations are made for the challenges of winter as we all face the reality of living with coronavirus. So what we heard was that, you know, lockdown for the first time meant that many people faced a loss of independence, and with this they experienced a total shift of mindset. They think of themselves sometimes as vulnerable or on a burden on others. This wasn't how they'd seen themselves before, and this wasn't how they saw their lives panning out, and they didn't like it, and they felt powerless to do anything about it. There was many restrictions on acute and community services, on visiting care homes, which caused pain and loss. We know about the challenges as was for residents and care workers, but finding the balance between protecting older people through infection control while enabling as much contact as possible with families is key to improving outcomes and quality of life. We also learned about the stress and the isolation and the increased levels of caring provided by carers, sometimes families making the decision to provide their own care as they feared inviting anyone into their homes. And we also heard about new assessments of cares or reviews, you know, being suspended and being difficult to access. And we heard of many people who weren't contacted by social services during lockdown to see if they were okay or needed help. And family carers were largely invisible during the pandemic and their need for support. So it placed the needs and services of older people under the spotlight. And as I said, yet many were felt invisible and not part of the decisions that were made about their lives. Some people even call themselves passengers in the whole kind of experience. They were worried about their physical and their mental well-being, and they were upset and angry about the assumptions that were made about them and fearful of discrimination, that they were deeply distressed about the devastating impact of the pandemic in care homes. So I think what we, sorry, I'll go back up and read this. I think when we're looking at the sort of what the previous speakers had said too, was talked about the rights, you know, the pandemic caused concern about the rights of older people, how they would be protected. There was a lot of discussion at the start about clinical decisions around access to ventilators and whether, you know, older people would have access, you know, second. And there was, you know, the whole sort of DNA and CPR was also major concern for people that were being asked these questions in a crisis situation when they were, you know, probably extremely stressed. So we got a lot of calls to our advice line about that. There was also the ageist assumption and prejudice about elderly and the diversity of older people. But, you know, and as we know in Northern Ireland at the minute, there's no protection from discrimination on the basis of age when accessing goods, facilities and services here. So it throws us back into the kind of UN principles of older persons, which is about ensuring independence, participation, care, self-fulfillment and dignity. But the pandemic challenged the government's ability to protect and promote these rights. And we need to ensure that as we move on into the new phase of the academic, the pandemic that this is addressed sort of face on. I just want to talk about some of the experience of the carers. And this is a young 32-year-old formal carer called Finn. And he, you know, what he says, it's difficult. Things had changed drastically at the start. We didn't have PPE, and that made things so difficult, particularly around infection control and end of life care. We were limited in performing the normal type of personal care, which was really distressing for the clinical staff and residents. Plus the responsibility of being the only person there at the end of life was in some situations overwhelming. Whilst it did get better with more PPE, staff changeover and the prospect of further restrictions is really worrying for care staff and families. We have a porta cabin with plexiglass to cater for visitors who are more mobile, or for more mobile residents, but I can't envisage what visiting will be like for the end of life residents, you know, in winter time. So while we've learned so much, it's difficult to say what's next due to staff sickness and constant staff turnover. There needs to be continued supervision and training to ensure new staff understand how serious COVID is. And he actually felt that, you know, there was kind of people were getting a wee bit more sort of relaxed about it. But I thought what he said was, it's cathartic to be able to talk about this, and that reflects what's been said before. It's difficult, you know, so I think it's important that these care workers are recognised for some of the trauma that they've been experiencing. I won't go into this one too deeply because I think Liz is going to share a lot more about the whole informal care, but this lady, you know, had retired to look after her husband, and she just basically felt that COVID meant that she didn't only give up her job, she lost her grandchildren, her gym, her friends, and her whole way of living, actually. And it was a nightmare in isolation. She said she lost her purpose and reference as a person, and her friendship circle and her family. So her description was, my world just shifted off its axis. Normally I'm proactive, but not sure how or where I can be proactive at the minute with all the uncertainty about. The next person I want to talk about is Martin and Siobhan, and they went to see their wife, Martin's wife and mother, Gillian, who was on her 80th birthday, and after 116 days of not seeing her, and they, you know, very, very concerned, very anxious. She also had been diagnosed with COVID, but you know, she didn't have all the symptoms, and so they went in, they saw you know, the presents, the gifts, everything was laid out for her, and they saw her through the window, and they said it was, you know, bittersweet. But what they highlighted was that how the you know, the love and care of the staff had reassured them. The fact that they had access to technology was, you know, enabled them to keep in greater contact. And, you know, this was a story that we featured in the, you know, writing all the newspapers across Northern Ireland. Martin's just said, you know, he was worried about her, but the sun would always rise tomorrow, and he had hope once he'd seen her, which I thought was very significant. So the whole report is centered around sort of an agenda for action. And there's four key areas. You know, the support, health and care side of things, communication and connection, loneliness and isolation, and grief and loss. And again, it ties into what's been said before, because it calls for a strategy on loneliness for Northern Ireland. It calls for social care to be recognised as an equal partner in how we provide for the health and care needs of older people, and a robust review into the COVID crisis in care homes. It also includes actions on important practicalities such as food delivery, shopping, and being able to use cash, plus the urgent need to address levels of frailty, to restart health and care services, and help older people stay as well and independent as possible, and to support families and carers with digital accessibility and keeping them connected. It also talks about having a properly resourced grief and bereavement service, which is what Patricia was talking about, and the community-wide need for us all to do something as we can as a society, reduce the impact of loneliness and isolation. So the fundamental principles are protect, respect, and don't forget. And the action points are for policymakers and political leaders responsible for the planning and delivery of public services and health protection. But there's also a message for us across the community, the wider community, to look out for our older friends and neighbours to ensure that they're not left behind. And AGNI will be following that up in November with our annual campaign, No One Should Have No One, with the emphasis that it's now more than ever that no one should have known. So thank you very much.
That's brilliant. Thank you so much for that. Another great presentation. So we're just now going to move on to the last one here, which is, as I said earlier, Fiona Mcmahon from Tide, and she is joined by Liz Stitt, who is going to talk about her own experiences of caring for someone during the pandemic. So if the two of you are ready, I think Fiona, maybe you were going to talk a little bit first. So if you're ready, just go ahead there. Thank you.
Good morning. Thank you for the opportunity to speak. I'd also like to thank the coalition of carer organisations who enabled us to take this opportunity. The first thing to say is that Tide is a network of former and present carers of people living with dementia. We're across the 4 nations, and we work to connect carers with each other and enable carers to speak up for the change they would like to see. So I just wanted to very quickly talk about the numbers. There's estimated to be 22,000 people with dementia in Northern Ireland. There's new stats coming out to say that up to 86% of people in care homes have some form of dementia. And in May, we were looking at 53% of all COVID deaths being in care homes. So potentially the impact on people with dementia and their carers is hugely disproportionate, as you can see. These stats are all within a briefing paper that's on the Tide website, and I'll be able to share the link later, and it's particularly around residential care. So the reality for people with dementia in relation to their experience of the pandemic so far, there's no doubt it's a different experience for them. The lack of contact with loved ones and social activities has meant cognitive decline. There's restricted movement in residential care particularly, which meant less physical mobility for people. The psychological impact of isolation and a limited understanding of why people weren't visiting or why they were shouting through a window can't be underestimated. People with dementia are more likely to have difficulty in using technology, particularly visual online contact. And the loss of mental capacity around routine, familiarity and stimulation can't be replaced. Reduced access to healthcare and rehabilitation has meant that function may be lost forever. So we're just starting to find out how it's been over the last 6 months with various pieces of research being done. I'll touch on carers, but as has already been mentioned, Liz is going to tell you much better than me how that's been. But I want to highlight just 2 areas here. The lack of care at home and the closure of day services has already been mentioned, but that has been huge in compounding invisibility. And the grief and loss issue, which again has also been mentioned. When you care for someone with dementia, you experience ongoing grief and bereavement. A person may be sitting in front of you. As they lose cognitive function, your relationship and your connection with them changes. These losses are grieved over and over. If you haven't seen that person for an extended period of time, that loss is brought into even sharper focus. So potential solutions, we've talked about the guidance here. Visiting regulations and guidance for residential care needs to take account of the rights of people with dementia and their carers. Already mentioned, there is supposedly revised guidance coming out very soon. Screening and safeguarding, also mentioned, and infection prevention and control being essential for all. I'm flagging up solutions because there are solutions to some of this. Crisis management is no longer appropriate at this stage. We believe that the guidance needs to show the rights of people with dementia and the rights of their carers, and it needs to be looked at in a longer term. We're not looking at the next 3 months here, we are looking at a much longer term way of managing care. And all this needs to be put into place for all of us. But that's enough about me. And from me, I'm going to hand you over to Liz, who's going to tell her story. This is the first time Liz has spoken about her experience over the past 6 months. And I'm just going to show you a photo of Frankie, who is Liz's husband. Thank you, Liz.
Good morning. My name is Liz and I'm married to Frankie. We have 2 sons and he has dementia with Lewy bodies. At the start of the COVID lockdown, things weren't really that different for us because Frankie would get anxious if he was in noisy or crowded places, and socially it was easier to take him out for a drive during the day. Then when the lockdown started, I would have been doing the normal daily things and caring for Frankie, not feeling as if I was in lockdown. My son would get the shopping and leave it outside the house for me. So that was the main difference. Things had started to change before COVID, and Frankie was starting to get very anxious and aggressive. A few times he was tested for infections, but all tests showed no infection. I needed support and help as the weeks passed, and because my son was working from home, he started to come into our house to help with Frankie. I asked for advice from a social worker who had been assigned to Frankie. We had never met her, and then because of COVID, she was not able to visit us at home. I rang her on one occasion to ask advice, and she suggested I made a memory box. I tried to point out that the last thing on my mind would be a memory box to help calm Frankie, and actually at times I would be very frightened by his behaviour. On a second occasion, I contacted her to ask if there was any out of hours number I could ring for things were changing. She suggested I play hymns to Frankie and asked could my church not help me. I couldn't even reply to those two suggestions, for this person truly knew nothing about us. I thought it was pointless and didn't try to contact her again. One day when things were really bad, Paul suggested I spoke to a doctor, and he in turn advised me to ring an ambulance. And at the end of May, Frankie ended up in Antrim Hospital. And again, after the usual checks, no infection. He then had a short stay in a unit to be assessed, but again, he ended up back in Antrim Hospital. Again, no infection. So that was almost 8 weeks in total away from us. The social worker based in the hospital communicated to my son throughout Frankie's stay and tried to get him a place for him. Due to his needs and COVID, this was the reason he was so long in the hospital. After 6 weeks of not seeing Frankie, my son and I started to visit him in the hospital. And although he knew us, there were changes in how he communicated with us. His cognitive skills seemed limited, but I think it helped him seeing us, and it helped me seeing him. I spent the time chatting to him. I massaged his hands, his feet. I cut his hair and nails. He would seem relaxed, and quite often he would fall asleep. At the end of July, he was transferred to a home in Ballycastle. It's an hour's journey there and back for us. But this home is able to meet his needs, and he was quarantined for 2 weeks. The visiting rules are one family member 1 day a week for 30 minutes. And when we got to see him, we seen more changes with Frankie. He didn't respond at all, and that afternoon of our first visit, my son got a call from the nurse looking after Frankie to tell us that a patient in the home had tested positive for COVID, so the home was now in lockdown. We weren't sure when we would get to see him. I clearly understand this decision had to be made for everyone's safety in the home, but it's heartbreaking thinking of him. Frankie left our home on the 27th of May, and I miss him every day. The professionals are providing the care he needs, but they are making decisions about if and when families can see their loved ones. At present, there is no visiting at all. Previously, we had a few visits inside the home, but mostly it was window visits, and trying to talk to Frankie is difficult. He's curling up on us. It's the contact with those who love him is what he needs. On a positive note, one visit, a nurse came out to my son and me and reassured us that Frankie was being well looked after, and that helped me a lot. I think about Frankie and wondering if he thinks we don't care. No matter how much my sons try to reassure me, I feel I've let him down. From the start of this journey, I've tried to be positive and made changes to the house to make things safer for Frankie. I took him to meetings for Dementia and to see other members. My son and I went to meetings to enable us to understand the way ahead, and then we got on with life, even though it was different and at times difficult. But nothing prepared me for how hard it would be watching someone you love disappear before you, or not able to see them and show your love for them as they disappeared. So what really upsets me about COVID is how it has been used as an excuse in not supporting vulnerable people. For I truly feel let down by the Northern Trust with their lack of support for Frankie. For although they couldn't visit us, the very least we deserved was a phone call to check on Frankie. And I would love to ask that question of someone in authority. I get a call or an email from Frankie's empowerment officer in Dementia and I every week. Ashley has helped me with advice or by just talking to me, and this is a small charity totally committed to their members and their families. I have really appreciated the time she gives me. It took a long time to understand carer and that I had become one. I'm not really sure if I've done a good job, but I know that when Frankie went into hospital and because of the COVID rules, I didn't have anyone to care for. I had no control in his care, and I am essential to his care. For if I am honest, some days I felt I wanted somebody to care for me, but I can't explain how, for I didn't know what was wrong with me. It's been 4 months since Frankie first went into hospital. I still try to be a carer, and I hope I get a chance soon to hug him and let him know I really care. Thank you.
Thanks, Liz. Really appreciate you sharing that with us, even though it was obviously difficult for you. I think most of us have probably had a rough time during lockdown and the pandemic, but just hearing what you've been through, like, I'm just really sorry. Like, it's been rough, and you know, there should have been more support in place for you, and it's just really disappointing that there wasn't. I don't know, Fiona, if you want to come in again briefly before we move to the questions and answers. Or are you okay?
I'm quite happy for the questions and answers, that's fine.
Great, thanks. So I think my colleague Kira has been keeping a little eye on the questions and answers. I'm just wondering, Kira, is there anything in there for the speakers?
Yes, I'm just gathering myself together after
Thank
that.
you.
Thank you so much for that, Liz. That was incredible and so so tough. Just let me see. There was a question here at the start from AMB Nuri. I'm sorry, I don't have a first name there. Question is, the Commissioner for Older People Act gives the Commissioner's Office power to take certain steps and do certain things to fulfill its function. Was that office active enough? What do you think? I'm going to just open that up to all of our speakers. Does somebody want to come in and answer that, please?
I can come in a bit because I know at the beginning of COVID, the Commissioner was really prolific about the care home situation, and he was, a number of times on Nolan, and he was very forceful with the Minister of Health and Department of Health around helping AGNI get support for their check-in and chat service, and he was very eager to launch that. So I think at the beginning, it would be fair to say that the Commissioner was highly prolific, and I would anticipate more coming through now, next week with older people's, International Older People's Day and Positive Aging Month. So we'll see more from him then. But yeah, I think he's been definitely supportive.
Patricia, do you have any views on that? I know that you mentioned the Northern Ireland Human Rights Commission and also the Equality Commission. Do you think that the Commissioner for Older People has a key responsibility here?
I think indeed, and I agree that the Commissioner took some very strong steps to go public at the beginning of this, and that helped us with the fact that we were pressing very strongly for real attention to be paid to what was happening in the social care sector. Have the enforcement agencies as a whole done what they need to do? And the two enforcement agencies are the key ones in this. I think there's a great deal more they have to do. At a time of crisis, when you are publicly critical of what is happening, you can be regarded as disloyal, betraying, rocking the boat. But by God, if you cannot rock the boat on the rights of the people who needed the care and the people who were also delivering the care, and that includes the family members, the informal carers, then when can you do it? We have been arguing about the centrality of social care in the healthcare system for decades now, and for decades it has been the poor and mostly forgotten relation. All of the outsourcing that has happened behind the scenes, behind closed doors, by default, not in a tangible way. I'm a union which for 20 years fought privatisation directly of healthcare services and won. But when it came to social care, it was about somebody in a back office taking a decision that we would no longer have the provision from the statutory healthcare sector, but we'd take it from somewhere else. Issues like procurement, how this is all being addressed, what protections, what equality and human rights protections are in the procurement process, big questions. And while we went public, calling on the government to step up and assist with the provision of PPE and guidance to the private sector, we still have very big questions about what kind of scrutiny was going on. And, you know, we've just launched a UK-wide campaign on social care, and we have an uncompromising position that it is part, in our view, part of the healthcare system and should be provided by healthcare workers. And it should be to the highest international standards, the training. And Professor Marmot said, when he did the big review of the healthcare in England some years ago, basically what McGranny used to say, you get what you pay for. He said very clearly that if you wanted a decent social care system, then you had to put the resources in, you had to pay the people, you had to train them, and then you would get the delivery out the other end. Now that's fallen on so many deaf ears. There's another question on here, but I'll wait until it comes because I have a lot to say about it.
Thank you, Patricia, and thank you, Siobhan. Just Liam Dugan, hello Liam, I know Liam well, has asked, what engagements have the speakers had with the Department of Health on the proposals arising out of the Power to People report? If you're aware of that, about reforming social care, for example, co-producing the proposals. Would anybody like to answer that question?
Well, I don't want to hog, but I have to say to you that Power to the People was the third major review of social care that Unison gave evidence to. And in the production of evidence, we produced evidence directly from the frontline workforce and from the clients and residents and their carers. And we did quite a lot of that work in conjunction with allies. Allies that we have worked with for many years through rights and community care, AGNI being one of them. Power to the People was the last of those reports. We didn't agree with everything in it because it was much too ambiguous about the provision of social care through the private sector, and that bit we rejected. But we pushed for it. First of all, we had to push very hard for it to be published. And there were lots of excuses given about the delay in publishing it. It came. The department then set up an advisory group. We have a seat on that advisory group. That advisory group barely met. The pandemic was used as an excuse. We pushed again. The issue of co-production, we've had to take this on consistently because we're not living in a co-production world at the minute. There have been, you probably know, a change in powers and functions at the top, the governance of the health system. And we have this new board that I'm very doubtful about and have challenged on. And we're now living in a world where decisions are being taken and handed down, and stakeholders like trade unions and the other organisations, many of you online today, are being, if we're lucky, involved in implementation. We're saying, no, that's not what this was about. This was about the democratic involvement of people. This was about designing the kind of system that the people need to meet their needs. And this was about true engagement. And I'm very worried, and we all need to be on our guard here, that the pandemic has been used as an excuse to do things that people with power wanted to do anyway. One of those things I know has been the increased outsourcing of social care, not the increased bringing of the care system back in-house, which is a program we've been pushing for some time. So we're not in a good space at the minute, but that is one of the major issues we're pushing on. I've met with the minister, met with the department, met with all sorts of people with authority, but I'm still very concerned that as we talk today, I don't have a handle on who is really taking decisions about what our current response to the pandemic is and what our future health and social care system will look like. And we all need to be very worried about that.
Thank you.
Thanks, Patricia. I'm just looking at our time here and we're actually starting to overrun, but I can see we have just 3 questions here. I'm wondering if we can try and rattle through them in the next 5 minutes, if people are able to hold on.
I was going to say, Robin, I suppose we started just a wee bit late. So
yeah, so an extra 5 minutes is probably okay. I also just wanted to say that loads of these messages are just saying thank you to Liz. So just thanks to everyone who shared that kind of comment. I'm going to try and pass those messages on to her once this webinar is finished. But Ciara, sorry, I'll let you take back over again.
That's okay, Robin, thank you. I would say that any questions that we don't get to, what we will try and do is, if it's okay with the speakers, is engage with them afterwards and see if they might provide a written answer, and we will send an email to all the participants afterwards as well, if everybody's okay with that. I'm going to go to Maggie's question. Can I ask Anne-Marie if there is a consensus about integrating social care into the NHS? I know in England there's a call for a separate equivalent to NHS and social care, but the feeling is that integration would institutionalise its Cinderella status. And people with disabilities in particular worry that right to independent living would be lost if we move to an outright medical model of social care.
Yeah. Certainly, even when integration took place here in Northern Ireland in the early 1970s, one of the big fears of social work was exactly that social work and social services would, be the handmaiden to the health services. Some of those fears, I think, have been realised, but maybe not the worst of them. I think there's 2 big questions here, really. One is, yes, we could have a universal social care service outside of the NHS. Is that likely for Northern Ireland? It's not, I don't think. In Britain, there's been a long tradition of social services being within local authorities, and there's pluses and minuses to that. I think the ultimate question is how we fund social care, whether it's, my opinion would be that it should be fully integrated into the NHS, but whether that's the case or whether it remains within local authorities in the rest of Britain, the critical issue is that people have universal access to it as a right in the way that they do to health services. That's never been the case for social care. And, all of these problems have been coming home to roost over the decade. So we need a social care system that's free at the point of delivery, that people know their rights, they know their entitlements, they have proper information about how to access it. But we do need to be looking at the integration issue, because this is one of the problems that's dogged health and social care for the lifetime of the welfare state, and not just the integration of health and social care, but the integration with the social security system and with housing and all of the other services. Could I just say quickly on the expert review, there was very little engagement with academics from the review panel on social care. And I do feel, some of the recommendations were very good, but they were limited from the outset, and that they were told they couldn't consider funding. And you can't do something like that without considering funding. And I think, one of the outcomes of that was one of the recommendations around charging for domiciliary care, which they were trying really to look at how they could make services better, but without addressing the fundamental issues.
Thank you so much, Anne-Marie. Just from Brenda, what do speakers feel about a family member being designated as a key worker and with necessary infection control training could access their family and support staff on a voluntary basis? Yes, Fiona, do you want to come in there?
Yeah, Tide as an organisation are part of a campaign called One Dementia Voice, which is supporting John's campaign, which is based primarily in England, but it's getting traction elsewhere. They're bringing a judicial review about this, about family and friend carers being given key worker status, which would mean they have access to PPE, infection prevention and control, and that visiting rights are upheld. I appreciate that key worker status may be a difficult one, and there's issues with worker and some of the language used around that. However, what we are saying is it is the right of people with dementia, it's the right of carers to have contact with each other in an appropriate way. And as I said earlier, you know, we all went into crisis management in March. This is not short-term crisis management anymore. This is the way social care within residential care and home care is going to be delivered in the foreseeable future. So we need to take account of the importance of family and friend carers, and acknowledge and recognise what they bring to the health of the people they care for, whether they're at home or in residential care. And there is increasing evidence coming out. I put a link up there with the research report that we did about the impact of the lack of contact, whether it's social contact within care home settings with each other, or whether it's contact with people who love you, and the impact that has had, and the continuing impact that will have if we don't sort it out now.
Thank you so much, Fiona. And I think that was just so clearly illustrated by Liz's story about the importance of Liz's contact with Frankie, not just for Liz, but also for Frankie. And I think, you know, that was just really powerful. I'm going to end the last question is going to be from Jessica Black to Patricia. Patricia, you mentioned some resistance in care homes to safety measures. Are measures in place to prevent the scale of loss in care homes in this second wave? Do you feel there is enough testing, and also what kind of workforce turnover are you seeing, and what are the implications of a high turnover? So I'm going to give you a challenge, Patricia, and ask you to kind of as briefly as possible speak to those questions. It's quite a lot to fit in there, though, so I just want to acknowledge that too.
Well, first of all, no, I don't think that we're at the right state of preparedness yet. I think a lot more work has to be done, and I want to know who's got oversight of that at the minute. Obviously, we have inside track because we've got people inside, most but not all of them. So we get the view from the workforce, but I really want to see regulators and monitors in there. I want to know to what extent there is a genuine stockpile of PPE, whether any care has been taken to reduce the footfall, that footfall being the transient nature of the workforce in many instances. I think the guidance needs further updating. I think we've got to be much more robust. I don't feel that we have yet put in place learning from the internal review they've conducted, let alone the public inquiry we're looking for. This can all be done, and it isn't for the want of us trying to make it happen, but it's a system that finds it very difficult to coordinate with itself, and I think that's one of the problems we have.
Thank you so much, Patricia. Robin, I'll hand back over to you.
Yeah, I'm sorry, I think we may have missed one or two questions there, but as we said, we can try and pass those on to the speakers after this session. Just like, thanks everyone, really. I think, apologies again that we've overrun a bit, but yeah, I think it was probably worth it just to cover all of that. I just want to say a big thanks to all the speakers, just excellent presentations all around, and just Liz in particular sharing her own personal experiences. Just thank you. It really added, I mean, it made the whole thing a lot more powerful just to see how things play out just in someone's actual life. So just thanks very much. So I'm actually going to stop the recording now and then just bring the session to the end. It's been a good session, and I just really appreciate you coming here. Thanks.
Thank you.